Hi there, it's Ross Miller again with a presentation entitled SoundBite Dental Records for Assistants. And this is for any person, be it a dentist or assistant or audiologist, who's interested in learning more about taking a good impression for the SoundBite hearing system. The topics in this presentation are a little review of what the SoundBite is, the impression taking technique, model, and a summary. SoundBite's a prosthetic device for treating single-sided deafness, or SSD, and conductive hearing loss. It's a non-surgical bone-conductive prosthetic device that transmits sound via the teeth. It's FDA cleared as a prosthetic device for treatment of single-sided deafness. It's a lower cost, lower complication alternative to prevalent surgical treatments that use similar mechanisms of action. We do require a little bit of different impression taking technique. You're not taking an impression for a crown, you are taking an impression for a bone conduction prosthetic hearing device. So we need the information around the tissues and the teeth, the palate, and the backside of the most distal tooth. It's for people with single-sided deafness and conductive hearing loss. It requires an accurate impression of both soft tissue and hard tissue. It's a SoundBite impression. It's not a crown impression. And you can take a SoundBite impression with a quadrant or full arch impression, and I'll tell you a little bit why we do both. Probably about 90% of the time you could do a quadrant. 10% of the time you might have to take a full arch and possibly a lower impression, but you need to know kind of both of those things. And we prefer alginate to silicone type impressions. I use Chromopan 100 in an alginator. It mixes things up very nicely and smoothly. Get it from Pearson Dental. The Impression 99 swivel trays, these work great. They're wider than a plastic crown trays. You can get the palate. You can bend these. You can put extra material up on the roof of the mouth. You can talk to our sales rep, and again, they're from Pearson Dental also. Actually, I think you can get them just about any dental supplier. Here we have a good impression on the right. Oh, I'm sorry. On the left, you can see how much of the palate we have on that and how much we got into the buccal, into the vestibule above the teeth. And on the right, not so good. We missed the palate. And sometimes if you miss the palate and you have a tori or something up there, we won't know it's there. So you really need to get the palate nice. Left, not so good. Middle, good. And a right, good. You can see where the limitations of full arch impression tray is. Sometimes you get a fold on the left and not on the right, or vice versa. But we need to get impression. But we need to get information all the way on the distal of the teeth that we're trying to put the ITM on. Don't use single crown impression trays. This is a SoundBite impression, not a crown impression. Before taking your impression, take a look at the patient's teeth. Look at the dental anatomy. Look at how the teeth, look at the occlusion. Look at the palate. Look at what's happening in that patient's mouth. Try in the tray, noting where the front edge of the tray is so you can duplicate the position when alginate is placed. Put excess alginate on the palate before taking the impression. Place the excess alginate on the lingual side of the impression tray. Take the impression, making sure it's seated and not moving. And then remove and pour up as soon as possible. I just did a series of slides taking an impression on a typodont. So trial fit, that's very important to kind of see where you are with the tray. Again, Chromopan and alginator. Go ahead and mix. You take 2 scoops of alginate. You want to have a little excess alginate when you take this impression, mix it up, and you can see how nicely that alginator works. The Chromopan's pretty nice. It changes colors for you, kind of tells you when it's mixed and when it's ready to go in the mouth. And you'll want to put excess on the palatal side and then leave a little excess in your bowl so that you can put that on your finger and put it on the palate. Here you see me putting it on the palate. Take your impression, and normally when you're taking a really extensive impression of that palate, you'll see indentations of your incisors, both incisors. This impression's pretty good, but you can see there's a few little rolls there. But it would work for SoundBite quite nicely. Some challenges that you need to worry about: palatal tori. Make sure you see those before you take your impression. You want to note those on your prescription form. Let us know you know it's there. Let us know you got a good impression of it, because it's important for us to. This is. You can take a quadrant or a full arch when you have a tori. You can do both. Then there might be orthodontic issues, some crowding on one side versus the other. All things being equal, you want to do this, do the impression on the side that's got the best dentistry or dental situation for the sound bite to fit. The BTE, if it doesn't fit or doesn't fit well, uh, no matter how well it works with hearing, it's not going to help your patient. So it's got to fit nice. Unfinished dentistry, make sure the dentistry is done. And then the occlusion. If you have an occlusal issue that you're not quite certain of, go ahead and take an upper and lower impression, full arch, and take an impression of the other side. We want to put this device, we want to put the ITM on the side of the best dentistry, all things being equal. When can you go ahead and use a quadrant? Well, when your upper teeth, uh, the most distal tooth is an upper tooth, is a great patient to do a quadrant tray on. Our wire hypotube goes on the distal side of those of the most distal tooth, and in this schematic you can see that the lower teeth are not going to hit the tube or interfere at all with that. But you need to look in the mouth, and the dentist needs to look in the mouth and make sure that that hypotube is far back, is going to be in a good position on that patient. The ITM should be out of occlusion. It's like a retainer. You really don't need to be patients shouldn't be biting on it, but they do need to be adjusted from time to time. Here's a case where the lower, it's sort of a class 2 patient where the lower teeth are farther distal than the upper. And you'll see this if you've had a upper wisdom teeth removed and lower wisdom teeth are still remaining or hyper erupted. That's why you really need to look in the mouth and judge these things. But about 90% of the time, a quadrant tray will do just nice, do perfectly for you. And then here you have some gingiva on the back, on the distal side of those teeth. That gingiva can be removed before a SoundBite is placed. It's up to the dentist in consultation with the patient. But if you're in a situation like this, sometimes a little, just a laser or electrosurge can remove that tissue so that this will fit nicely. Ensure the model includes an accurate dental anatomy and soft tissue extending to within at least 2 to 3 millimeters of the midline of the palate, 2 to 3 millimeters past the gingiva of the buccal side, and 2 to 3 millimeters past the last molar on the distal side. So we basically need to get all around the most distal teeth, getting really close to the palate. Alginate material should be used to take the impression. PVS just doesn't work as well. And please do not send impressions. Just send us a nice poured-up model. These are some examples of some poured-up models. Look how much palate we have. But if you do a PVS that has a knife edge, it's not so good for us to work on. Or if you grind off the palate, it's not so good for us to work on. Two good ones, or actually all of these are pretty good ones. Just make sure you get enough palate and you get enough tissue around the teeth. Why does PVS sometimes yield not so good impressions for us? Well, you get a knife edge, and you can't flow out about on the tissue unless you unless you really are focused on getting a SoundBite impression. This is clearly a impression tray that is for a single crown or a single unit impression tray, and those just don't work great for a SoundBite. You got to get up on the palate, you got to get past the most distal teeth, and you got to get in the vestibule. So they're great for taking impressions of crowns or onlays or inlays, but not so good for us. Pour up the model. Go ahead and do dental stone. Our lab uses dental stone, high strength, but you can use just about anything. This is just the ETI Empire Direct is a product that we use internally at Sonitus. But we take upper, full arches, quadrants, what have you. We can work with any stone, but just do not modify the model. Don't grind on it. Don't take away material, because we need the model, as much of the model as we can to make a good ITM for you. Here's a display of an actual ITM going from counterclockwise from the actuator that produces the sound. That is on the buccal, and the actuator nub is the only part that should touch the teeth. There's a battery that powers the ITM. There's a palatal acrylic and a hypotube that connects the wire to the battery, that connects the actuator to the battery. And there's electronics in there, so you don't want to damage this tube. It's not a wire. It looks like a wire, but it's a tube. There's electronics inside of it. In summary, this is a SoundBite impression. It's not a crown impression. Before you take the impression, identify the problem areas before the impression. If you have a tori or if you have occlusion, that's could be a potential problem. A crossbite, high gingival distal to the upper teeth, or posterior crossbites, you may require a lower impression. You may require a full arch. Okay, if there's any questions, take an upper and lower full arch. Pour up the model, but do not adjust the model. It's a great way to help your patients hear better. Do's and don'ts: do use alginate. Don't use PVS. Do use a swivel tray. Don't use standard plastic single unit impression trays. Those are a way to get a bad impression right off the bat. Do take a full upper and lower arch when in doubt, when occlusion is in crossbite, and do have sufficient palatal information. 90% or more of the cases that we have to get new impressions on are because of insufficient palatal information. And don't trim the model. These are devices that are out of occlusion, but if you have any question about the occlusion, take a lower model. Thank you very much for listening. Again, this is Ross Miller, DDS MS, and we're at www.soundbitehearing.com, and you can reach me at rosssonitus@gmail.com. Thanks for listening, and have fun with this new product for your patient's hearing.